Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And as you know, this is your show. And one of the things that I thought we'd like to do today is talk about the general issues related to the health care of children in our community. In other words, the general atmosphere relative to child safety, health, the pressures that are placed on children. So a lot of you who are grandmas and grandpas that are watching the show, listen up, because we're going to talk about a lot of things, including everything from saving a child's life, potentially saving a child's life, to some of the emotional issues. So let me introduce our guests. And we have two very special guests. We have Dr. David Reitman, who's sitting in front of me. He's an associate professor at Nova Southeastern University, College of Psychological Studies. Welcome, David.
Thank you.
Or may I call you
Good to
David?
be here. You may call me David.
Okay, you got it. And Dr. Deborah Mulligan. What a star. She's a professor and she's a director of the Institute for Child Health Policy here at Nova Southeastern University, and I will say proudly, a fine pediatric physician and the first woman president or president, correct?
Yes.
Of the Florida Society of Pediatric Physicians. Welcome.
Thank you.
I know that you have a specific area of interest, and I know that not only with reference to I would say little ones, little children, but also I would say adolescents and children. And I know you work very closely with the Boys and Girls Club and with the school system. So tell us some of your activities relative to children and the health care of children in our community.
Sure. Well, I'll tell you a little bit about what we do here on campus at the university at the Center for Psychological Studies. We have a clinic for ADHD children. We serve...
Tell us what ADHD is.
ADHD is attention deficit hyperactivity disorder.
Right.
And we serve them in a clinic with an acronym for a name, ACT, A-A-C-T, which is the ADHD Assessment, Consultation, and Treatment Program. We serve children that are between the ages of 2 all the way up to young adults of about 22 years of age. We provide very comprehensive evaluation in our clinic, and we also provide treatment, which is increasingly unusual. There are a lot of people that provide assessment and then send you somewhere else, presumably to get care. We like to provide the whole continuum and really link assessment together with our treatment program. We also, as part of our assessment, but also as part of our ongoing evaluation of what we do, we visit schools. We will occasionally do home visits. So we really take the C and the ACT program, the consultative piece, very seriously. We also reach out to physicians that the children may already be working with to try to coordinate our activities as opposed to pit them against one another in an unproductive kind of way.
How do you, it's just sort of a intellectual curiosity on my part, because we read so much about, and there are many advocacy groups that are out there that fight against the use of certain pharmaceutical agents in the area of attention deficit disorder and hyperactive children, et cetera, but I'm not going to get into that battle. But I will say to you, though, that there are a lot of people that, how do you overcome the what I would call PDR consultative medicine approach, where some physician might just look at a monograph and say, well, this is for attention deficit disorder, and move on. I mean, I'm sure that they're not doing it with any harm, or they intend to do any harm, but how do we reach out to the community at large, medical community, the mental health community, and let them know that it's really a comprehensive, I guess you could say, not only through evaluation, but consultative, because a lot of it has to do with family environment. not
Yeah,
correct?
you're completely on target. In fact, even the American Academy of Psychiatry and the Child Division in particular they have practice guidelines that very clearly spell out that the best practice approach combines psychotherapy, behavior therapy, alongside of pharmacotherapy. So it's pretty clear that the frontline treatment is really never an instance where you would only provide medication. In fact, what's interesting, the research has revealed that long-term, the kinds of things that really matter the most are not the symptoms of ADHD, the things that people think of first off when they think of the diagnosis, attention problems and things of that nature. The things that matter the most in terms of long-term outcomes are the things like family environment. So if you promote better family relations, you get better long-term outcomes. Peer relationships and academic performance are also very strong predictors of long-term outcome for children with ADHD. And interestingly enough, those kinds of symptoms cut across almost all behavioral disorders for children. So it's a way of creating a broader perspective about children's mental health and the things that we need to be targeting. So in terms of a community-based intervention, those things need to target not specific symptoms of disorders, but family functioning, peer functioning, and academic performance. We do those things well, we'll get a lot of return for our investment.
You know, and I guess I'll throw this out to both of you, but you know, there's something that always comes up, I guess, almost, now we've been doing this show for almost 10 years, and I remember the times that I've spoken to the different eye care physicians, the ophthalmologists, the optometrists, and then the audiologists, and I always say to them, well, in audiology it's less of a problem because through the advocacy of the Florida pediatric physicians, children are tested at birth for hearing disorders. But children are not screened or tested for eye function, I mean, other than, you know, neurologic function. And often a child is placed into a classroom by either size, alphabetical order, or social security number, and a child that might have some kind of vision impairment might be back in next to the last row, can't see anything in the blackboard or otherwise, and then is labeled with ADHD.
Yeah.
Is that, you see that?
Yeah, and when that happens, what it generally reflects is a poor evaluation. You know, one of the things I mentioned, you know, without specifying exactly what went on, was the nature of a comprehensive evaluation. Well, part of a comprehensive evaluation, in addition to visiting the school, speaking with teachers, observing what is actually happening in the classroom, interviewing parents, interviewing siblings, and interviewing the child, him or herself. In addition to that, we also do a pretty comprehensive history that reviews the physiological systems. And if there hasn't been a recent medical exam, one of the first things that we do is recommend that the family go and get that so that we can rule out those kinds of issues. Because clearly you're banging your head against a wall as a psychologist or a other mental health professional if you haven't established that the person can see, hear, etc.
Well, it always amazes me, Dr. Mulligan, Deborah, it always amazes me that we label so many children as dunces, dumb, non-attentive or otherwise, because they have a physiologic problem known as an impairment, a visual impairment. And yet they're not paying attention because they just don't see the board, or they you know, something happens, they're dyslexic, they have all kinds of visual relation problems.